When we find a cancer diagnosis on just screening mammography, it typically is an early breast cancer, meaning it's a small breast cancer that typically has not spread to the lymph nodes or to anywhere else in the body. So when we find a breast cancer at that early stage, it's very treatable. What we know is that stage 1, stage 2 breast cancers have well over about an 85 to 90% 5-year survival rate.
So is it curable at that point?
Yes, early detection is the key. Breast mammography saves lives. By identifying these breast cancers at an early stage, you have a greater than 90% chance of a cure and 5-year survival rates.
Okay, that's awesome. So then I have friends, we'll be sitting around, and a friend of mine said to me, I don't have a family history of breast cancer. There's no cancer in my family. I don't need to get a mammogram. Thank you very much. So what do you say to that?
Unfortunately, she still has a risk of developing breast cancer. What we quote women is, on average, 1 in 8 women will have a chance of getting diagnosed with breast cancer at some point in their lives. So 1 in 8, that's a pretty large statistic, so somewhere about 10 to 12%. And what we know is that of all the women who are diagnosed with breast cancer, only about 5 to 10% of those are actually genetically linked, meaning that those are breast cancer diagnoses related to a strong family history. About 90% of women who are diagnosed with breast cancer do not have a family history or strong family history. So it's important that we still go get your mammograms.
So Dr. Kodali, does that mean that the
Yes,
patients that you see, they don't have any family history?
Close to 90% of breast cancer patients that I see do not have a family history, and they're worried and have questions as to why they have this breast cancer, since no one in their family had breast cancer.
Good to know. So I would like to talk about now, okay, you're telling me I need to get that mammogram every year, and it can be a little nerve-wracking because we all worry about the exam itself. Is it going to hurt? Can you tell us a little bit about the process?
So there's a few different types of mammograms that are out there. There's what we call the 2D mammogram as well as the 3D mammogram. The 2D mammogram is what we consider to be our gold standard mammogram, and that's what's been used for screening for many, many years. It can be slightly uncomfortable for women, but I think I would just want to stress that the early detection of finding anything abnormal outweighs any hopefully any negative experience with the mammogram.
Right.
So a 3D mammogram is also a very acceptable method, and it actually we are able to get thinner slices of the breast, meaning a better pictorial representation of the breast for the radiologist to look at.
So is it a clearer picture? Is that why they have gone from this 2D to 3D?
Yes, the 3-dimensional image is a clearer picture and helps with a higher detection rate and less recall rate for subsequent additional imaging or testing or biopsies.
Oh, well, I like that because I don't like the callbacks. I know I've had a callback myself, and it's very, very nerve-wracking.
Yeah. Yes. I think it's important to note that both either the 2D or 3D are very good methods, and still to this day, the 2D mammogram is considered the gold standard for breast cancer screening.
Okay. So ladies often ask me, what can I do to keep from getting breast cancer? I mean, is there anything I can do? Can I change my environment? Can I change the way I eat? Or what do I need to do to mitigate or reduce my chances of getting breast cancer?
So some of the risk factors that we think of for breast cancer, besides the genetic risk factors that we will go over later, includes age, being a woman, gender, and other environmental factors such as cumulative estrogen exposure in the lifetime. So that includes early menarche, late menopause, use of hormone replacement therapy, use of birth control pills. All these can increase breast cancer risk. So these would be the risk factors. In addition, we also talk about smoking and alcohol. So
I think, jumping into the risk factors that we can change, we know that studies have shown that you can actually reduce your breast cancer risk by about 30% if you make certain lifestyle changes. So what does that include? Vigorous exercise, at least 2 to 2.5 hours of vigorous exercise per week, making sure you're not living a very sedentary lifestyle, eating well, getting all those good antioxidants in your diet on a daily basis, limiting alcohol to perhaps about a glass of wine a day for a woman, an average age woman, and also keeping your body weight in check. What we know is that obesity is linked to having more estrogen in the body, which can increase your risk of developing breast cancer.
So what other factors, did you talk about age? I mean, or as we get older, I've heard that women have a higher risk of getting breast cancer. Is that true?
Yeah. Age does increase your risk of breast cancer. Children don't get breast cancer as often as adults do. And as we grow older, those environmental risk factors combined with your estrogen exposure increases your risk. However, having said that, about 10% of all breast cancers occur in young women under age 45.
So what exactly are the symptoms I should look for? Because I know, should I go to, I've heard the term clinical exam, or then myself when I'm taking my shower, what should I look for? What should be like a red flag for, should I go see my provider or my OB-GYN doctor?
So I think you can sort of break that question down to two components. One is what we call you're doing your self-breast exam or breast self-awareness. And that entails just knowing your own anatomy, knowing what your breasts feel like, as well as the lymph nodes in the underarm area. Understanding the contour of your breast and then what your nipples look like. If you start feeling any new lumps, any changes to the nipple, any nipple discharge, or any skin changes to the breast, those can be worrisome signs and you should go get them checked out. In addition, we still advocate for a clinical breast exam. And what does that mean? It means a breast exam performed by either your primary care physician or your OB/GYN.
As a physical examination.
Right. So skin changes, you mean like, will it pucker, or would there be does it get darker?
It may be a discoloration of the skin, or orange peel appearance of the skin, or or an ulceration even of the skin can be signs of breast cancer.
What about, I know this is kind of an icky thing to talk about, but about nipple discharge. I know I've heard women say I'm suddenly having some nipple discharge, and so would you speak to that?
So nipple discharge can be worrisome. In the majority of instances, it turns out to be related to a benign or non-cancerous issue. However, if you are experiencing nipple discharge, it's important to go to your provider to get it checked out.
It indicates probably a blockage of one of the milk ducts, and that may be related to a cancer or sometimes a benign condition that's blocking the milk duct.
So, heaven forbid, I've gotten the bad diagnosis or the bad news that I have breast cancer. So, what next? What's going to happen now?
So, I think it's important that now you will need to establish care with an oncology, either medical oncologist or surgical oncologist. It's important, I think, for a patient to make sure that they go to a comprehensive breast program, one that has a medical oncologist, a surgical oncologist, a radiation oncologist, and a breast radiologist. All of those players, in addition to pathology, social work, nurse navigation, are very integral parts of the breast care team.
So how is that important as far as determining my care? You know, the buzzwords out there right now are individualized care. You're not going to have the same cancer treatment as your sister or your aunt. So how does that play into the multidisciplinary approach that you're just talking about?
So early detection is the key. I always say mammogram saves lives. So if we can get the diagnosis at an earlier stage, we have a higher chance and success for a cure. Now, God forbid you do have the diagnosis of breast cancer. What do you do next? So the next step is to find your multidisciplinary team of care that you're comfortable with. Breast cancer treatment involves several aspects of care, which may include, besides the surgery, which is the key component, in addition to that, sometimes radiation treatments and sometimes chemotherapy treatments and sometimes other targeted immunotherapeutic treatments or anti-estrogen treatments. You need to find your care team that is comfortable, that you're comfortable with, that you're going to sit down. They talk to each other and they sit down in a multidisciplinary team fashion and individualize the care for you. Everybody's cancer is different, although they are all breast cancer. The only common thing about it is it's arising from the breast.
Okay, thank you. That really helps kind of explain things for me, because I know that when I'm working with patients or friends and we talk, a lot of this comes up, like what next, what do I do? So I do want to shift gears a little bit and talk a little bit about genetic testing, because that's all the buzz right now. People are getting their own kits, or they're wondering, should I get tested? I had a friend say to me, my grandmother had breast cancer. Should I run out and get a genetic test? What do you think about that?
So I think genetic testing is very important. The more knowledge you have, it's the more power that you have, and you're empowered in terms of your care. In terms of the guidelines for genetic testing, they're pretty extensive, but they can include, if you have a personal history of breast cancer at an early age, you should go ahead and get tested. If you were diagnosed with ovarian cancer, if a close family member has metastatic prostate cancer or ovarian cancer, or also a breast cancer diagnosis at an early age, it's important to get genetically tested. There are other criteria as well, and so if you are worried about your risk based on your personal or family history, it's important to go ahead and speak to your primary care provider or your OBGYN about the next steps.
So Dr. Kadali, I do know that you've got some special training in genetics, and so I would like to ask that who needs the testing? How do you decide that? And then where do I go to find that out? Because I know that it's hard to find people that do have this particular expertise. So if you could speak to that a little bit for me.
So in the United States, approximately 1 in 500 women would be estimated to be BRCA1 or 2 gene mutation carriers. Not everybody who has the BRCA1 or 2 gene mutation is going to develop breast cancer. They have a slightly increased risk of breast cancer compared to the general population. The risk we're talking about is in the order of, if the patients with BRCA1 and 2 carriers will have 50 to 70% increased risk, whereas your general population risk is approximately 10%. So I want women to think having a gene mutation doesn't mean a death sentence, doesn't mean that this is going to be breast cancer for them tomorrow and it's going to happen no matter what. It's more empowering them to know what to expect and what can they do to help prevent or reduce that risk, and what can they do to help for their family members. So the first thing I encourage is, if for women to understand their risk, talk to their family, understand their family history, know who has breast cancer, what age, what other cancers do they have, and then bring it up to their primary care physician or their OBGYN and ask them, discuss with them about genetic counseling. So before you proceed with the genetic testing, which can be a blood test or a swab through the buccal mucosa, they should be aware of what they're getting into. What is the result going to mean to them? That's what a pre-test genetic counseling means.
Right. So it's important to get an expert.
It's important to get an expert who is able to do the pre-test genetic counseling, go through their at least 3 generations of pedigree, and explain to them what those results would entail if they were tested positive, or what other testing may be additionally done if they come back negative, and then proceed with the testing. So the genetic counselors or providers, physicians, experts who have special training in genetics would be able to do this in a more comprehensive breast program fashion, rather than go through direct consumer testing of a website.
Right. So where would I look for this, doctor? Like I know for you, do you provide genetic services? And so is it like a family practice visit, or how?
Yes.
What's the process?
So
for
it's
that?
considered actually a preventative visit. It's good to start with an oncologist's office that is close by to you. And most oncologist offices are equipped with and may be able to provide the genetic counseling services, especially if there's a comprehensive program in that area. And that's where you start with.
Okay, that sounds great.
Yes.
So let's see. You answered the question, several of my questions, and finally, I'd like to talk about. So again, back to if I find out I have cancer, God forbid, can we talk about the different, you talked about the multidisciplinary approach. So can we talk a little bit exactly what kind of doctors will I be seeing? Because I know that it's very overwhelming. You might see 2, 3, 4 doctors. So what kind of doctors will I be seeing?
So every,
I'm going to ask Dr. Shaw to start with the surgical aspects.
Yeah, because that's the most important component.
Well, I think every breast cancer diagnosis is different, and everyone, depending on the stage, the breast cancer type, will be treated in a very different way. So if you know a breast cancer survivor, their treatment may be different than what's offered to you. In terms of the surgical approach, typically there's 2 different types of surgical options that are available to women. Again, this depends on your tumor, the type of tumor, and your own personal history as well as your personal values. But we have what we call breast conserving therapy, which means we're removing through a small incision, just removing the tumor and a rim of healthy tissue around it. And that's usually followed by radiation for a few weeks at a later point. The other alternative that we have is what we call a mastectomy, in which we remove the entirety of the breast. Plastic surgery can be involved in either of those components. I think it's important for a woman to know that reconstruction is their right, and if they do proceed to undergo a mastectomy, that they should seek out a consultation with plastic surgery to at least discuss what options they have.
So you're the other doctor you'll see, a medical oncologist, and then can Dr. Kadali, could you also speak to the other doctors that may be involved in the team?
Yes. So a medical oncologist is involved in the treatment of breast cancer, typically by giving non-surgical treatments. That's the medical treatments include chemotherapy or anti-estrogen endocrine type of pill form of therapy, other targeted immunological or biological treatments. So most of the time, the first time that a patient with a newly diagnosed breast cancer comes into my office, they have the horror face. First thing they ask is, do I need to get chemotherapy? And I totally understand chemotherapy is hard, but in reality, in this day and age, majority of the breast cancer patients do not require chemotherapy. About 70% of breast cancers are related to specifically estrogen-driven, or what we call estrogen receptor-mediated. And majority of the early estrogen receptor-mediated breast cancer are not requiring chemotherapy anymore. We actually treat them with anti-estrogen therapy. In addition to that, there are 2 other subtypes of breast cancers that do require more aggressive treatments, such as triple-negative breast cancers, as well as anti-HER2 directed breast cancers. The field has come a long way in terms of targeted treatments that are that have a high success rate and high survival rate. We talk about adjuvant therapies, that means in addition to, that is after surgery or before surgery, to help reduce that cancer risk, if we do it before surgery, the treatment we say it is to help shrink the tumor size. And if we do this after the surgery, it is more to prevent any microscopic cancer cells that may be left behind. In case of advanced cancer, stage 4 setting, then our goal may not be a cure, and we are more directing towards prolonging survival.
So you've talked about the systemic treatments like chemo, and but what about radiation? What is that? How does that play into all this? Does everybody get radiation?
So not everyone will get radiation. As I mentioned, typically women who undergo breast conserving therapy with just what we call the lumpectomy procedure, they will usually go on to get radiation. Of course, there's a large subset of patients who may not even need radiation therapy, but that's what's typically recommended. There are some indications, even after a mastectomy, in which the entirety of the breast is removed, that a woman may need radiation. And typically what radiation therapy is it's radiation that's delivered to the whole breast every day of the week for a few weeks. And that's administered by a radiation oncologist.
That's exactly what I was going to ask you. So is that another doctor I'm going to do?
That's another provider, yes.
Okay.
Mm-hmm.
Okay.
Yes.
Yeah.
So when I go see the radiation oncologist, would I see him before my treatment starts or after my treatment? How does that work?
It may just depend on the institution or the providers that you're seeing in terms of when you see the radiation oncologist.
Okay, and then he'll determine how often I would get radiation?
So we start the radiation treatment after the surgery. If there is any need for chemotherapy treatments, we typically do the chemotherapy before the radiation treatments.
Okay, oh well, that's good to know. And typically, how long does this all take? I know that patients are so concerned, and people that in the beginning, what am I going to do? I have a wedding coming up. My kid's going to be graduating from high school or college. So what's going to happen now with all that?
So particularly in the setting of early stage breast cancer, which again is a reason why we highly recommend screening mammographies. In the setting of early stage breast cancer, usually you would get treatment first with surgery, and that would usually be scheduled within a few weeks of your cancer diagnosis. Following that, then you'd have a recuperation period to allow yourself to heal and get better from surgery, and then radiation therapy would typically follow. An early stage breast cancer that does not need chemotherapy. So that whole process would be from diagnosis to completion of radiation therapy, probably about a few months.
Okay. And then if I needed chemotherapy, so I would have it after my surgery typically, and then, go ahead, Dr. Kadali.
Chemotherapy may be a longer time frame.
Okay.
Depending on the type of chemotherapy, the type of cancer, this may vary anywhere between about 12 weeks, that is, if you're just getting 4 sessions of chemotherapy, or it may be up to 6 months. And sometimes for the specific subtypes, such as HER2 positive breast cancers, where we give biological treatments for almost up to a year or longer.
Okay.
And it may vary in terms of whether you get chemotherapy first before surgery, or surgery first followed by chemotherapy.
Okay, good to know. So I would like to talk a little bit about, it's so unusual, but there are men that get breast cancer. So could you speak a little bit about the prevalence of male breast cancer, and do we treat it any differently?
Yes. So men can get breast cancer, but it is 100 times less common than women breast cancer in terms of statistics. If we think about 1 in 250,000, 250,000 breast cancers statistics in the U.S. For women, I think, and for men it is 25,000. It's 100 times less in terms of the statistics. Most commonly, breast cancer in men is genetically mediated. So one of the risk factors that we talk about, for all men who develop breast cancer, we do recommend genetic testing, and they may be associated with BRCA1 or BRCA2 gene mutation. And there are other cancers that can happen in this category. They can have prostate cancer, pancreatic cancer, melanoma, other type of cancers as well. The treatment is somewhat similar in terms of the surgery or chemotherapy or radiation recommendations. Dr. Shaw can explain the surgical aspect of it as well. And in terms of because men do not think of breast cancer, they're not aware of findings of a lump in the breast or change in their breast tissue. That may be something that we need to be made aware of in this Breast Cancer Awareness Month about men. Yes.
Okay. So I want to go to some of the questions that are coming in. So is radiation exposure a concern when you have regular mammograms? So what about the radiation that I'm getting from all those mammograms?
So the amount of radiation that you're getting from either your 2D or 3D mammograms over your entirety of your life is actually pretty low. So we say that the benefits of getting your mammogram and that small radiation exposure outweigh any of the risks associated with that radiation exposure. So it's perfectly safe for majority of patients to undergo their annual routine screening mammography.
Okay, awesome.
And there is not much difference in the amount of radiation between 2D and 3D mammography.
Okay. Another question we have is, my mom had several cysts removed. Does it mean that I will also have to have cysts removed from my breast?
Unlikely. Most cysts are not genetically mediated, so it was probably just a benign happening in your mother. So I would not worry about your own risk of breast cysts or breast cancer.
What about when you hear about women that do have to have certain cysts removed or certain lesions? Can you speak to that a little bit? Are they cause concern for eventually getting cancer? Or?
So I think in terms of what we talk about with breast disease is that there's sort of a spectrum of some breast disease that's completely benign, meaning it's non-cancerous and will not increase your risk of developing breast cancer over the period of your life. But there are certain findings on after surgery, some atypical findings that can increase your lifetime risk of developing breast cancer. If those findings are found, usually your care will be further managed by your surgical oncologist as well as your medical oncologist, and may, in some cases, can include medications for risk reduction as well as enhanced screening with MRIs and mammograms.
Okay. I'm going to go on to the next question. What type of doctor should I see if I find a lump? And should I start with my primary care doctor? So how does that all happen, that I would go and get that lump taken care of?
So I think you could be either. You can either go to your primary care physician or your OBGYN, or you can seek out a breast specialist. It's important to whichever provider that you see, that you have a good history, you're able to tell them a little bit more about how long you've felt the lump. And usually the next step they will usually do a breast exam and perhaps order some additional imaging such as a mammogram or ultrasound to further evaluate.
So it would start out with an order from them, and so would I have just a screening mammogram, or would I start out with something different?
So in women who come in with an actual breast-related complaint, in most instances we will actually proceed with what we call diagnostic imaging. So that's a little different from your regular screening imaging. So diagnostic imaging is still your mammogram, but it includes some additional views, some more specific views to get a better picture of that area of concern, and can also sometimes include an ultrasound as well to also help look at that area that's concerning.
Okay. So I'm going to go to the next question. Let's see. A really good question. What should I get a special kind of mammogram, or do I still need to get mammograms if I have implants? So many women have implants now. some women are afraid of getting a mammogram, that it might damage their implant. Can you speak about that?
So still go ahead and get your routine screening mammography, even if you have implants. At sometimes your plastic surgeons may want MRIs, but that's usually for a different reason related to the implants. And the MRI will not replace getting your mammograms. So it's still important when you get even after breast implants, to get your routine screening mammography.
Okay, awesome. So I guess the next thing I want to talk a little bit about, what got you into the, how did you decide to be a cancer doctor? And I'd kind of like to know a little bit about your journey, Dr. Kadali.
So over my life, I've seen with family and friends, a lot of my family and friends go through the journey of cancer. Breast cancer is near and dear to my heart, but also other cancers. I started out with first research in immunotherapy treatments in immunology. This was 15-20 years ago with my medical school training. And little did I know at that time that immunotherapy is going to be the next greatest advance in cancer care. So at that time, with the immunology background and immunotherapeutic treatments and research, and with my family and friends and my own passion, that's how I got into oncology. So I trained in my residency in Massachusetts and fellowship training at University of Minnesota, and I have been in as a medical oncologist here with HCA Houston Healthcare in this Clear Lake area for the past 10 years now. And I really enjoy what I'm most passionate about is actually prevention and early detection. I have an interest in cancer genetics, and also I have a great interest in survivorship, which is the fun part. Once we have our patients taken care of, their treatments are done, and they're going through their second, third, fourth, 5 years, and 10 years of their life, and we really become friends. And they come to our yearly visit. They talk about their family, what's going on in their personal lives, and it's really rewarding to see this.
That's awesome.
Yes.
So I still want to hear about you, Dr. Shah, but I've got another question.
Yes.
So if my mom had breast cancer, how likely is it that I'm going to get breast cancer?
So it's not a very straightforward answer that I will give you. I think it's important to know a little bit more about your mom's history as well as the rest of your family history in terms of, when your mom was diagnosed with cancer, what stage and what type of cancer she was diagnosed with. And additionally, in terms of your family history, there are other factors such as your own personal history, if you've ever had any breast biopsies, any abnormal mammograms, what we mentioned, your lifetime estrogen exposure, such as if you've ever had any hormone replacement therapy, or your age at first period, age at menopause. So all those play a factor into understanding your risk of developing breast cancer. So I think your concern is definitely valid, and I think it's important that you go to talk to your physician at your next annual visit.
And Dr. Kadali, what would you say about that person in mammograms?
So one thing I will add is 1 in 8 women develop breast cancer in the United States. So even if your mom had breast cancer, it may still be a non-genetic acquired breast cancer because breast cancer is so common. So I would still continue with your mammograms and further understand your family history to see if there is any need for genetic testing at that point. It also depends on what age mom had breast cancer, etc.
So what would be the age? If my mother was older and she had breast cancer, what's the difference if she were old or young? How does that play into it?
Most often, familial or genetic breast cancers occur at a younger age. We think of age under 50 or 45 even. Multiple family members on the same side of the family, and multiple other similar gene mutation related cancers in that same side of the family is what we would be looking at. So if mom had breast cancer in her 70s then, and she's the only family member with breast cancer, then I wouldn't worry so much about your family history or genetically driven breast cancer, but I would still continue with your routine screening mammograms.
But what if she was younger?
If she was younger, then so the recommendation for genetic testing, if you have a personal history of breast cancer under age 45, is to actually get genetic testing. And if, say, mom is not available for genetic testing, then the family can be considered for, first-degree relatives can be considered for genetic testing because of age of one family member at a young age with breast cancer.
So if my mom had breast cancer at 45, when should I start getting my mammograms? Is it still 40?
So this you would first go with a pre-test genetic counseling and see what your risk factors are. So if your risk factors are purely, mainly consideration is because of mom's history, then you can get genetic testing done, and if the genetic testing is negative, then I think you can still start at age 40. On the other hand, otherwise we would talk about 10 years from the age that mom had breast cancer. And if you have other additional risk factors, what do you think about it, Dr. Shah?
I agree. I agree.
Okay, awesome. So I have another question. So I am a smoker, if I am a smoker. I'm not a smoker, but if I am a smoker, does that increase my chance of having breast cancer? I get this questioned a lot. I do have some friends that smoke, and they wonder that they know about the lung cancer piece, but they're worried about, is it going to increase their chance for breast cancer?
So smoking does increase risk for breast cancer. We don't have hard numbers in terms of what percentage, like the lung cancer does. But also, in addition, smoking affects the treatments too. Dr. Shaw can discuss about the surgical issues that happen, that they talk about for smokers.
Certainly, if you are an active smoker, at your breast cancer diagnosis, it may impact what kind of surgery we offer you. Unfortunately, people who do smoke, we know that their tissues just don't heal as well, so we may not be as aggressive in terms of our surgical management, meaning an active smoker we may discourage from getting a mastectomy with reconstruction because we know that it may impact their recovery, their healing, and moving on to subsequent treatment. Meaning, if they undergo a mastectomy with reconstruction, they are more increased risk of developing complications, which can delay any chemotherapy or radiation therapy that may need to happen. In addition, smoking, of course, we know that it does increase your risk of just complications for anesthesia as well. So, another plug for smoking cessation.
Yeah. So let's see. God forbid, I know that I have met some people that have been pregnant and they got the diagnosis of breast cancer. So if you're pregnant and you get diagnosed, are there treatments available for you during pregnancy? And can you both speak to that?
Absolutely. With a pregnancy-associated breast cancer diagnosis, all the treatment modalities are still available, including surgery and chemotherapy and radiation. Of course, the stage in which some of these treatment options, in terms of the trimester of pregnancy, will help guide some of the treatment options that are available to you at that time. But we still remain very aggressive with our breast cancer treatment during an active pregnancy.
Okay. Dr. Kadal?
So believe it or not, chemotherapy is safe in pregnancy. Not all chemotherapy medications, but some of the chemotherapy medications. So if the breast cancer is diagnosed at an earlier phase of pregnancy, we actually start with chemotherapy and then pursue surgery during their second trimester. And if it is diagnosed at a third trimester or later phase of pregnancy, then we still give chemotherapy as a bridge until they can deliver and then move on with their subsequent treatments.
If there is a need for radiation therapy, that's usually delayed until after delivery.
Yeah.
So I'm seeing another question. I see commercials for new drugs related to breast cancer. Are there any new treatments?
Yes, there's many new treatments for breast cancer. If we look into the different types of breast cancers, so as I was talking to you earlier about the anti-estrogen therapies, so we have a number of targeted treatments specifically directing to CDK4/6 inhibitors that are now available for metastatic stage 4 breast cancers, in addition to the anti-estrogen pill to help prolong their survival in stage 4 breast cancer. Just recently, ESMO, the European Society of Medical Oncology meeting, is going on, and there are some new studies out there about another agent, the alpelisib, that has now also in combination with anti-estrogen therapy, which is specifically directing another mutation, another target, the PI3 kinase inhibitors. The anti-HER2 type breast cancers have a number of biological targeted treatments specific for the HER2 receptor, both in the early stage setting as well as advanced setting. And finally, the most aggressive breast cancer that we worry about is the triple negative breast cancer. And in the triple negative breast cancer, we have a number of immunotherapy treatments that are now coming up as in the clinical trials as shown to prolong survival. Last but not the least, for the BRCA1 and 2 gene mutation related breast cancers, we actually do have a specific target for those BRCA1 and 2 gene mutations called PARP inhibitors that have shown great promise in terms of preoperative therapy as well as in stage 4 settings. So this is actually great news. I always say breast cancer is one of the leader in terms of research compared to any other cancer out there. So we really do great with breast cancer research, and I hope we can get going to the point where we can say no more chemotherapy at all.
Right. That would be awesome.
Yes.
So it sounds very exciting about all these targeted treatments. So when I'm initially diagnosed, do they test my cells for these particular targets that you're talking about and these treatments?
So we do talk about personalized treatment for breast cancer. One size does not fit all. It's an older age where everybody got mastectomies and chemotherapy, and that is it. But now, once you take the breast tumor out, for certain types of cancers that is hormone-driven, which is the majority cancers, we do check a molecular gene signature testing called Oncotype or Mammogram. There's 2 different products or companies out there, and we are able to predict based on their proliferative rate of that specific tumor what the risk of recurrence is, what we call a recurrence risk score, that can determine whether there is benefit from doing additional chemotherapy to prevent cancer recurrence or not. And also it's a good prognostic indicator, meaning, how aggressive is this cancer, what are my chances of this cancer, and survival in the long term.
So these special tests will tell you sometimes if I need to proceed with chemotherapy. So those are some decisions that we talk about with individualized treatment that we're going to have to make.
Absolutely.
Yes.
So, okay. So I have another question. And this may come to, I do want to kind of lead into what's your feeling? There is a new emerging field now for nursing, nurse navigation. So I'd like to ask you what role a nurse navigator plays in your institution and with as you work with HCA.
So I think a nurse navigator an integral part of the breast cancer team. Oftentimes, the breast navigator is the point of first contact for that patient when they've been diagnosed with breast cancer. So the nurse navigator will help guide them a little bit in terms of what it means to have a breast cancer diagnosis. These are the important aspects that you should be picking up for your pathology report, and this is what may be involved in your breast cancer treatment. I think the navigator also really helps the patient navigate the whole process. I think is a really good emotional support for the patient as they're going through surgery, chemotherapy, maybe losing their hair with chemotherapy, the radiation. Additionally, I think the nurse navigator model also provides a lot of wonderful support in the survivorship period. Now that the person has completed all their breast cancer treatment, what it means to move forward with their lives, after having completed all that treatment.
Yes, I do think the patient navigation through the nurse navigation system is a key role, and the nurse navigator is vital in terms of helping the patient, not only first giving them the bad news, but they are able to, because they know the patient before, as well as giving them all, providing that all the information they need, all the questions they need to answer, and getting them to their doctors in a timely fashion. Often it's within 48 to 72 hours appointments, and they're really there hand-holding all along their journey with their cancer treatment and care. Debbie, you're a nurse navigator. Tell us your experience of all this. How do you feel?
Well, I know it was a bit of a self-serving question that I asked y'all, but I did want you to speak to the importance of navigation to the physician team, because quite often we do try to bridge that gap sometimes between the patient and the physician. Some patients are very intimidated about their upcoming treatments. And unfortunately, sometimes we have patients, and I'm addressing this now because I saw a question about insurance. And so initially we help patients who are uninsured to be able to negotiate and find some insurance. We help guide them to get Medicaid if they qualify, and we can help them get signed up. There are some services that the state provides. So we try to help patients with understanding the importance of getting their treatment started, navigating, if you will, these financial questions. And then most importantly, we start out with that conversation about what does this mean, this weird oncology speak that we're all talking, we talk in this strange cancer language. And we try to break it down for people and give them tools. We present all our patients with an informational kit that we get from the American Cancer Society that goes over starting with, so they'll understand their path report and their imaging reports. We try to really empower the patient so that they'll be ready to navigate their journey, if you will, for this individualized care. Many years ago, I know I've been a nurse for 43 years, and it used to be all patients got deforming mastectomies, chemotherapy, radiation, and now I feel like we're trying to give patients so many more options and also not overtreat the patient.
True.
We want to get rid of your cancer, but we don't want to overtreat you.
True. Yeah.
So I would kind of like y'all to speak to that just a little bit, because people are so frightened about treatment. And I'd like to talk about how manageable treatment is.
I think the wonderful thing about breast cancer care is that we've been able to, in some ways, become much more minimalistic in our approach. As you've spoken to, from the surgical aspect, women used to get disfiguring, radical mastectomies long ago, and that was slowly transitioned over to a modified radical mastectomy. And now, women with early stage breast cancer can get a simple lumpectomy, which leads maybe 1 or 2 incisions in the breast with minimal cosmetic changes, if at all.
Okay.
And same thing with systemic treatments like chemotherapy and radiation and all too. Less is more now. So we try to find ways to avoid giving chemotherapy as much as possible, and try to be more smart in targeting the cancer and understand the language that the cancer speak and target against, by using specific biological treatments.
I think what we know about a breast cancer diagnosis in an older woman, say in her 70s or 80s, is a lot different. It's a much different disease than a woman who's diagnosed with breast cancer in their 30s. And so that really guides our treatment. And so I think we have the opportunity to be a lot more minimalistic in our approach with older women who are diagnosed with breast cancer. In some instances, it could just be as simple as undergoing a lumpectomy and then being on hormonal therapy.
Agree.
So finally, Dr. Shah, you're not off the hook. How did you decide to become a breast surgeon, and what kind of special training did you have to undergo?
So I completed 5 years of general surgery training, and during that training process, and actually even in medical school, I had some really wonderful mentors who were surgical oncologists, and that was really my drive for going into general surgery. I saw the technical aspect, and that really appealed to me, but also the patient-centered approach, the amount of care that goes in outside of the operating room for the patient, and so that's really what drew me to the field of surgical oncology. And moving forward in my residency training, I particularly was really enamored with the field of breast surgical oncology. I really loved working with women patients, and I really saw how this is a field where I can really be an advocate for a group of people. And so it was just a very easy decision, and it felt very natural for me to go into this field. So after my general surgery training, I did a 1-year specialized fellowship in breast surgical oncology, where I spent time with surgeons, but also with the medical oncologists, the radiation oncologists, the pathologists, the breast imagers, to get a very good understanding of the comprehensive approach that goes into breast cancer treatment.
Okay, so I'm going to wrap this up. So I just want to say that if you want to get your mammogram scheduled, that we'd like you to go to hcahealthcare.com/breast cancer awareness, and you need to get those, I guess we're going to say it together, those yearly mammograms starting at the age of 40. Thank you.
Right.
Have a great day.
Thank you.
Thank you so much.